Good afternoon, good evening. This is the American Nephrology Nurses Association Diversity, Equity, and Inclusion in Healthcare. This evening, we will be covering Module 3, and so this is a series of 6, and we are now on Module 3, which is health equity. Dr. Stamps is being let in now, and she will introduce me as a speaker tonight. Dr. Stamps, are you ready?
Yes, good evening, everyone. Good evening, Dr. Caldwell. We're so excited to be here on Module 3. Dr. Ebony Caldwell is the Vice President, Diversity Officer for Rochester Regional Health. She comes with many years of experience, and we welcome her back to Module 3. She's launched our education and training series, and really pleased to have her back with us tonight.
Thank you so much, Dr. Stamps. So tonight we're going to stay with the same objectives that we have for the entire series. One is to define and level set on common language. We want to discuss bias and racism, identify concepts and strategies to mitigate bias and eradicate disparities, and then build our toolbox for leaders and foster a culture of allyship. And so our agenda tonight is to talk a little bit about the background and why health equity is important. We're going to talk about some drivers of health inequities, discuss social determinants of health, health disparities, and how we can advance health equity, and then we'll have a summary and some questions. Time for Q&A. So health equity, here's a little bit of background. In America is browning and graying more than it ever has before. In 2020, in 2043, minorities population will become the majority in the US. In 2060, minorities are projected to be 57% of the population, moving up from 37, which they are now today. In 2060, we'll also have 1 in 3 Americans will be Hispanic. And then the percent of Blacks or African Americans will increase from 14 to 14.7% in 2060. Asian Americans will double in 2060, and then the number of immigrants is expected to grow by 41.2 million. And then we're aging as well. So by 2060, the number of Americans aged 65 and over is expected to double, and 85 and older will make up almost 5% of our overall population. And so this is the reason that we focus on health equity. This is why it's important, because we're promoting diversity in healthcare because it's critical to how we serve several patients and how they benefit. These advantages include reducing care and disparities. It helps us improve the optimized care delivery systems, and then it also helps us improve access to care. So health equity, according to your ANNA glossary, the definition is the state in which everyone has the opportunity to attain full health potential, and no one is disadvantaged from achieving this potential because of their social position or any other socially determined circumstance. This takes us into our drivers of health inequity. Discriminatory laws and policies, current and historic, affect many drivers of health inequity. So when we think about segregated schools, when we think about redlining housing laws, when we think about food deserts, generational wealth, and broadband access, these are the long-standing or current issues that we're dealing with and which cause a lot of health inequities. As a result, many communities experience unhealthy community conditions, be it violence, drugs, and pollution, structural drivers, which is housing, education, and employment. And then we also have unhealthy personal exposures and behavior in tobacco, alcohol, or nutrition. These disproportionate vulnerabilities are experienced before they come into our health system, sometimes during and after. So before they even get into our ecosystem, a lot of our communities, a lot of our population is behind the eight ball. And so we need to really focus on these disparities because they end in disparities in diagnosis, treatment, and mortality and morbidity. And so getting to communities and populations before they even enter into our ecosystem is part of the work that we have to do. We also need to be aware that health inequities are systemic differences in the health status of different populations and groups. And we have horizontal inequities where people don't have the same access to the same resources as others. And then we have the vertical inequities where people have high need, but they aren't provided with the greater resource. And so we'll talk about the resources and how they pan out or how we use them to combat disparities. And then some of the benefits of DEI for health equity are workforce diversity. It's also cultural competency, which we really have graduated or moved toward a philosophy of cultural humility, but sometimes the literature lags. So our cultural competency or cultural humility, and then our communication are the benefits that we can see from DEI to help move health equity forward. When we talk about workplace diversity, we're talking about how we attract, recruit, and retain a diverse workforce to help promote health equity. We're also talking about those promotions and succession planning, especially when we think about generational diversity. We have 4 generations in the workplace as we speak, but a lot of our baby boomers are leaving the workplace. So how are we looking at how Gen Z, Gen X, Gen Y, how are they working and what can we do to mentor, sponsor, and help stretch their uh, understanding and application of DEI and moving health equity forward. We also are thinking about all different types of diversity. This is a common misconception. People think diversity is about race only. It is not. We're talking about diversity of gender, diversity of ability, diversity of age, and so on. And so those are the things that we need to be focusing on when we think about a workplace. We know that the strategic equity journey enhances employee, students, and patient experience. And so when we think about this journey, we're thinking about how it is similar for employees. When we're looking at how we attract and retain employees, we're looking at performance management and we're looking at promotions and retention, we can get to a more diverse workplace. When we're looking at students and how we give them the tools that they need to help serve our communities, help excite them about a career in healthcare or a career in nursing. We want to make sure that we're giving them the skills they need, the wraparound services, and we're teaching them about wellness because if we're not well, we can't serve our community. And that gets us to workforce development. And then the other journey that's tied in here is our patients. When we think about access to care, data collection and metrics, as well as patient-centered care, that gets us to health equity. So all 3 of these journeys are inextricably linked and enables us to deliver health equity. We also want to think about the cultural humility. Historically, medical attention was provided in communities where patients had a similar cultural and racial background. To be to effectively and efficiently treat patients, we must appreciate the impact of culture on healthcare. We're talking about the culture of the patient, culture of the medical provider, and culture of the treatment or medicine. All of these often influence adherence to medical advice, patient satisfactory, and patient outcomes. And so we want to make sure that we have ongoing education and awareness opportunities for new and veteran employees to nurture the workplace and the culture. We must continue to learn about people's culture. That's exactly what cultural humility is. We can never know everything, so we have to continue learning. Learning is a lifelong journey when we're in these spaces of healthcare, education. When we're serving people, we're always continuing to learn about their needs, their culture, because that is going to allow us to get a better outcome. So, thinking about um, health equity, why we need it, why it's important, how it ties into diversity, equity, and inclusion. Now we need to think about social determinants of health, which is another concept that is something that we have to understand and that we have to do the work in order to find the benefit. Again, from your ANNA glossary, social determinants of health is conditions of the environment in which people live, learn, work, play, worship, and age, right? Is affects a wide range of health, functioning, and quality of life outcomes and risks. So when people are in conditions with no employment, or health systems and services are good or not good, it can be on either side of the spectrum. Housing is available or not available. The physical environment is a good place for them to get out and do exercise or not. Public safety is an issue or it isn't. And then we have social environments and transportation. All of these things affect our health, our functioning, and our life expectancy. And so when we think about social determinants of health, we think about the environment in our communities and how it affects our health. This definition from the CDC almost says the same thing, but social determinants are circumstances that we are born into, we grow, we live, we work, play, age, and then this one says, and die, right? And so we know that we're born into circumstances marked more by disadvantages like poverty, um, then statistically we will live sicker and die sooner, right? And so that's the work that we need to undertake when we think about social determinants of health. Yes, people are born into these circumstances, but how do we get them out of those circumstances sooner, or how do we educate them about those circumstances better so that they are living more quality lives, healthy and quality lives, so that they can live longer and live healthier. Okay. And this is just another way of looking at social determinants of health. Reducing disparities across our community leads to healthy outcomes. In healthcare, availability of health providers as well as cultural humility leads to higher quality of care and healthier outcomes. The other factors shown in these columns impact healthy outcomes as well as the ability to receive quality healthcare, right? And so all of these things, economic stability, neighborhood and physical environment, our education, the food that we have access to, our social circles or support that we have, and then healthcare systems all lead to our health outcomes when we think about mortality, morbidity, life expectancy, and so on. Okay, so health disparities is this is another definition in your glossary. Um, this is the health differences that adversely affect groups of people who systematically experienced greater social or economic obstacles to health. And this is all linked to discrimination or exclusion, right? And so when we have these disparities, our life or our health can look like this. But if we put in the work to reduce health disparities, to mitigate bias, and to make sure that we're seeing the full patient in front of us and respecting their culture and their wishes, then we can get to health equity where everyone has that ability to have the highest potential of their health. And the garden can look like this. But if we don't tend to it, it looks like the first picture. And I don't know about you, but I don't want that around my house. I don't want that in my neighborhood, right? I would much rather have the second picture. Okay. And so that's what we're striving to get to, that beautiful garden for everyone. Um, we also, I think, mentioned once before, or at least in that social determinants chart a few slides ago, is education is a big part of disparity. If we don't have good education, or our schools are segregated, or our schools don't have the resource, then we don't have the literacy we need to make timely and relevant health decisions. And just for an example, here in our area, we have one of the most segregated systems, school systems in the state, right? We have a border between our suburbs and our city schools, and education is lacking in the city. So it makes a difference where we put our resources so that we can get to the best healthcare possible. You'll see in a couple slides from here, we are going to talk about how the only way to really combat health disparities is if we hit multiple things at multiple times. So we're looking not only at healthcare, but we want to look at housing, we want to look at schools, we want to look at transportation, because all of those things are affecting the outcomes of health disparities. Um, this is a video that we're not going to try to play because we had a little bit of technical difficulty in the beginning, but it will be in your resource packet. Minority health disparities, and if you listen to Michelle's story, she talks about how growing up, I want to make sure that it doesn't play, so I'm going to move to the next slide. So she talks about how when she's growing up, that the way they ate, her family ate, she had no idea that it was not good for her, not good for her health, and that years later she would experience high blood pressure and diabetes. But it was embedded in her culture, embedded in traditions of her family, embedded in how they sat around, and food was something they used if they were happy, or food was something they used when they were sad. And the way they ate was cultural. Not until her children went off to college, and then they came back eating a little bit differently, and substituting turkey for beef, or eating more salads than carbs. She learned from a younger generation, her children, who learned from their experiences by going out into the world. So a lot of our health challenges, and a lot of our health habits are come from our culture and our upbringing. And so that is why we need to understand people's culture. We need to fully understand them in order to give them advice that they will adhere to. But that comes with the understanding and the trust that we build with our patients. And so I want to talk a little bit about advancing health equity. We just heard about all the different things that could drive health inequities. And we usually start right from the inequity. We want to know, so we have all these problems, how are we going to fix these problems? But we don't necessarily try to figure out what happened before. And so I love this quote by Desmond Tutu. He says, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And so that's why we want to do the work to understand where health disparities come from, what the drivers are, and how we can affect outcomes even before they enter our health ecosystem, how we can get into the communities to support advancing health equity. Another thing I wanted to share here is Equity 2.0, which it comes from the Belonging Institute, and they talk about targeted universalism. And targeted is an implicit assumption that only the targeted group needs support. But that's false, right? Universalism is this approach that assumes that different groups, different people are situated in the same or equivalent ways. That's also false. So targeted universalism is a way of looking at things, not only a policy strategy to get beyond fighting over, is it targeted or is it universal, But it also serves as a way to overcome a narrow focus on equal treatment. Jumping into creating change strategies based exclusively on the presence of a disparity is inadequate, and it does a disservice to the people that we're intending to benefit. The goal is not and should never be to equalize the resources. Remember, we talked about vertical and horizontal, but achieving a universal goal is what we're trying to do. In some cases, this will require unequal resources. So, for example, in 2021, white men committed suicide at a rate of 10% higher than African American males. The goal would never be to increase the rate of suicide for African American males. So instead, we would talk about providing equal or even greater provisions to white males to help achieve a universal goal of decreasing suicides. And so I hope that that example makes sense about how we look at resources. Sometimes it will be unequal the way we disperse resources in order to equalize the problem that we're trying to address. Target universalism framework manifests the understanding that we are collectively better off when all groups advance towards a shared goal. And here is some work from the Pew Research Center, where it talks about how we're browning and graying more than ever before, and we need to really look at financial gaps, business and moral imperative, and look at equity, safety, and quality. This is the IHI Achieving Health Equity White Paper, which gives us some great guidance for healthcare organizations. And I pulled one of the frameworks out of here, which has 5 steps that are very interesting in how we move organizations toward achieving health equity. One is make health equity a strategic priority with leadership commitment. Number 2 is develop a structure and process to support the work, dedicated resources, and structure and infrastructure across the organization. We also want to deploy strategies with specific targets, behaviors, environments, and social economics. We want to recognize and address and decrease institutional racism with organizations. We want to look at the physical, financial, access, and culture, norms and tacit rules. And then finally, we want to develop partnerships with community organizations, leveraging assets in the community to allow community voices to become part of the solutions. Dr. Stamps, are we doing okay on time?
Excellent. Yes.
Okay, great. And then this is advocacy. This is an opportunity for advocacy and allyship, which is a big part of the health equity journey. Transplants for all. Everyone needs a kidney, should have a kidney. So this initiative advances transplantation and living donors through education, research, and innovation and policies. We also have take race out of the transplant, which is an initiative to remove race from the medical kidney donor risk index algorithm. Race and ethnicity and clinical calculations have harmed patients' perpetual racism in kidney care. And so this will help make this equal, but it won't necessarily make it equitable, right? So we want to note that this initiative or change does not necessarily mean kidney care or healthcare becomes equitable, because we still need another step to repair the harm for patients who were harmed by not being on the list before. And I do want to mention that the National Kidney Foundation is lobbying for modifications of the wait times for Black patients and patients of color who were put on a waiting list incorrectly due to the EGFR calculations. And then finally, storytelling is powerful. Personal stories help Washington understand how kidney disease policies reforms are necessary and the positive impact that they have on patients and their families. And so, if you have patients that have a great story, please, and all of them do, please encourage them to submit their stories. We also have another opportunity here for advocacy. The National Academy of Medicine's 21 report, The Chart of Path to Achieving Health Equity, um, has a campaign calling for support and advocacy, and you can sign up for the newsletter. You can join the collaboratives. You can join an Action Coalition mentor nursing student, and that is the mentoring a nursing student always sits is tugs at my heart because Deb and I work at a College of Health Careers where we had lots of nursing students that needed mentoring, and they are going to be on those front lines. And so, if you can't join a coalition, if you're not ready to do the collaboration, mentor a nursing student. And then here is a call for action. You want to make sure that we're embedding racial and social justice into our organizational plans to advance health equity. We want to build alliances and share power. A big part of this work is about building and maintaining relationships. We need partners and networks to extend our reach. We want to foster pathways for truth and healing. We can't move forward without understanding what came before or without trust. We also want to acknowledge historical effects when addressing all determinants. Remember to stop just pulling people out of the river. We need to go upstream and find out why they're falling in, and then ensure equitable structures for innovation using qualitative and quantitative data. Don't overlook or discount the small ends, and diverse teams can be a real asset, and we need to appreciate the collective knowledge they bring. And so my last slide here is that we are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. So procrastination is still the thief of time. We must move past indecision and have action now, working on health equity. So I'm going to turn it over to you, Dr. Stamps, to open up for questions.
Thank you so much, Dr. Caldwell. Amazing. I always learn something. And health equity is really our true north in healthcare. There really is no other way to provide care to be able to adjust actions for those that we are serving based on their social determinants of need, and making sure that we have equitable processes. I am looking currently. I do not see anything in the chat or questions in the Q&A. We have some participants on. Please feel free. Oh, there's a question, Q&A. Thank you for a great webinar. Thank you. Thank you for the opportunity.
Thank you for participating.
Any questions? I will share a couple things that's happening here at the ANNA. You mentioned mentoring students. We actually are launching a mentorship program with students in Utah, and those students will have the opportunity to actually have an internship in a nephrology setting. Again, a way to expose our younger, newly graduated nurses to the specialty of nephrology nursing, because it's more than a dialysis machine. It's really about how do we provide holistic care and services, and how do we also think about how we can prevent kidney disease. You know, managing your blood pressure, for instance, is really important. And certain medications, knowing how those impact your kidneys.
That's awesome. Yeah, when we I was at a conference last week that they talked about a lot about generations in the workplace, and really focusing on our younger workers is going
Mhm.
to tell us how we can pro- progress in the future. And so really giving them that foundation and support and building community around them. And nursing
Mhm.
is all about service. So why not start with serving one another as we serve our community?
Absolutely. Oh, great. We got a question. How can we ensure that we keep DEI moving forward? I've heard a number of universities are no longer supporting DEI efforts. And it
Yeah,
really
and so
goes,
oh, I'm
Mhm.
sorry.
No, go
Go ahead,
ahead.
Dr. Stamps.
No, no, go right ahead.
So
I'll
I
take,
was
I'll,
just gonna
I'll, I'll
say,
take a,
yeah. So it really is about humanity, right? And so we can take labels off or on. Diversity, equity, and inclusion is ensuring that everyone gets the best care possible. And that's what hospitals and ambulatory sites and all of us are doing anyway in healthcare, right? And so you can take the label on or off, but we're doing the work, and that is what we need to continue to focus on, how we give the best care possible to every person, the right care, right time for the right person.
Absolutely. Awesome. Um, and interesting enough, it's not just universities. There are 29 states that have federal legislation pending um, on anti-DEI efforts. So it goes actually beyond the universities. And fortunately, when you think about many of our healthcare organizations, we're here for the people that we serve, as Dr. Caldwell mentioned. And if we think about population health, what do the communities need? If we think about healthcare disparities, we know that there are um, race, ethnicity, gender differences in health outcomes. We know that zip code matters, regardless of where you live in the country. And if we stay focused on identifying what those disparities are and taking appropriate action, intentional action, we can combat regardless of the laws, because we're here to provide the quality of care and services to the people in our community. Any others? We have time for one more. Okay. Well, you have our contact information. If you ever think of anything, we'll be back again next quarter to bring another uh, training session. And oh, someone says there's a question in the chat. Hold on. Hold on. Here we go. Um, I'm not sure. Oh, this session was truly helpful. This session was amazing. How do we combat the politicization of DEI? I think we spoke a little bit about that. Thank you for putting this together and done an excellent job on delivering. Thank you for this presentation. I appreciate this. It was wonderful and is a mainstay to healthcare. I'm not sure if you want to get into this, but how do we combat politicalization of DEI? Great session. This was great. This is indeed, this is needed in the dialysis community. Thank you for a great session. Thank you both. Um, again, I think if we can focus on providing the highest quality of care, the law is not going to be against providing high quality care, right? Those sometimes these actions are distractions, but if we stay focused on providing the care, um, that's our true north. Thank you again, Dr. Caldwell. Always amazing. I appreciate you. I wish we worked together every day again, but these moments together are amazing. I thank you very much. And I thank you for all of our participants this evening. And we will see you again soon.
Thank you so
Thank
much.
you.
Thank you.
Thank you.